Sachin Kale sir for kind introduction. We are here for much awaited CME, that is Jeevan Amrut Epidemiology Summit 2022. Since last 3 years, first was very gloomy with this COVID and everything around. Now we have started with this physical CMEs. Though it is not completely physical up till now, hybrid CMEs we are going through. And still COVID is around because two of our guest speakers today got stuck with COVID illness and they are not here to attend this CME, not in even position to come online as well. So we are running a little bit late. We are starting rather than 9, we are starting at 9:30. I'll be covering first lecture of today's session, that is CBC Interpretation. Along with that, as Dr. Vinod Patil is not available, I am covering his lecture as well, which is when bone marrow engine stops working, that is pancytopenia. So let's start with today's CM. First of all, thank you everyone for joining in physically and even online. I am very much overwhelmed with the response because more than 500 delegates are there who have joined in online to us for this interesting CME, and also from the students who have come all the way from various places from Maharashtra who are preparing for their quiz, which is going to be happening in the afternoon. I am not someone who is very expert. You all are expert. You treat many patients daily. You have very busy OPDs. But I know a little bit more about this CBC hematologist. That is why I am telling on this side of diet. So I want this dialect to be two-directional rather than me teaching something. If you have any questions, please feel free to ask, because this is something which keeps you learning when you have questions in your mind. What is the basic of any doctor or any clinician is to find the cause. The boss is to say anyone can treat, but to diagnose what is happening with the patient, that requires the skill. And there comes the investigations. And first and foremost, for almost every patient, we all do is complete blood count. But unfortunately, because of our busy OPDs and lack of that habit to pay attention to detail, we usually miss some things in CBC because just we don't read it completely. So let's make it a point, we start to read complete blood counts completely. This is what the routine CBC looks like. The routine hemogram looks like. Nowadays we have got many upgraded versions of this CBC machine. 3-part, 5-part, even 6-7-part filters are there, which give much more information, many more parameters as compared to the previous ones. These are the less known factors or parameters which are given in the CBC picture of that hemogram printout, like immature reticulocyte fraction, absolute reticulocyte count, reticulocyte hemoglobin percentage, mean platelet volume. Even without seeing smear, you can say that looks like MPV is around 16, 18. Patient might be having immune destruction of platelet, or patient might be having pseudothrombocytopenia just because filter is not calculating that properly. Even immature platelet fraction. These are the parameters one must keep in mind. But still, we can't ignore the fact that still manual microscopy is very important. Today we have one more lecture on this also, because morphology can't be out of sight. Still we have to see the film under the microscope to see morphology, size, correlation with the shape of RBC, WBC, platelet. Also to confirm WBC and platelet count under the microscope, because we can't rely just on machines. And also to diagnose many of the hematological conditions which can be diagnosed mainly on the microscopy only rather than the computer or other machines. So first parameter is usually given is the RBC count. Many times we get call from physicians or colleagues that, sir, I have a patient who has hemoglobin of 9, his RBC count is 3.9, his hematocrit this, all these parameters are almost same. Hemoglobin, the hematocrit is usually 3 times the hemoglobin value, and the RBC count is far more important when it comes to the diagnosis of thalassemia minor. Because in thalassemia minor, usually RBC count remains okay or on the higher side, and if it is iron deficiency anyway, it remains low. That is what Menzer index is. When you RBC count by MCV you calculate. So paying attention to that RBC count is very important to diagnose or even suspect the thalassemia minor. And if thalassemia minor is suspected, rather than blindly treating that patient as iron deficiency anemia, you can go for EHP electrophoresis to confirm the diagnosis. Polycythemia is also common disease which usually gets missed. Last week only I had one patient who was moving here, there, everywhere just for fatigue, tiredness, not feeling okay. And he was seen by almost every pathy, including neurologist. Finally, neurologist says that looks like there is something wrong in your first blood report where your RBC count looks like 7.9 million. Hemoglobin was 17.1 and it was polycythemia. We just had to start aspirin, do one phlebotomy, and now he feels wow, I feel very better now. So that is how it is. So paying attention to this RBC count is important. Hemoglobin, we all know, we usually ignore that fact that hemoglobin 9.7 I think a female से कमी जाता है. No, that's not the point. We have to have the target of around 12 for all individuals, also just to keep in mind. So giving attention to that hemoglobin value, it has to be normal, also important. MCV is very important. Whenever I get call for low hemoglobin, I usually ask what is the MCV. If it is more than 95, we can call it as macrocytic. If it is less than that, we call it as microcytic, less than 75, and normocytic anemia. So if it is normocytic anemia, one must have to pay attention, one must have to see whether something wrong is happening. But in India, it is common to have normocytic anemia because usually patients have diagnostic anemia, not just iron deficiency. It can be both iron deficiency and megaloblastic anemia, where rather than developing just MCV low or MCV high, patient develops normocytic anemia, and it has to be treated both as iron deficiency and megaloblastic anemia. MCH and MCSC are also important values which give us idea about the RBC overall size as well as overall concentration of hemoglobin. MCSC is usually high in cases of hereditary spherocytosis. It is also very important. Whenever patient is having some hemolysis going on, MCSC will be on higher side. If it is very high, you can suspect hereditary spherocytosis. So depending upon MCV, grossly you can divide what type of anemia it is. If it is microcytic anemia, more likely in Indian scenario, it will be iron deficiency anemia or anemia of chronic disease or thalassemia minor. And as we have already discussed, if MCV is low, immediately pay attention to the value of RBC count. Last week we had one hematologist father who was getting treated for iron deficiency anemia, though he was having thalassemia minor, because we feel that we don't get what we see. He was there having hemoglobin of around 10, 11, little bit of tired fatigue, maybe because of hypertension, maybe because of any other reason. But hemoglobin came low, and the hematologist he got into attention that your hemoglobin is low. Let's start with oral iron, not responding, give one dose of IV iron, and then finally at the age of 63, he gets diagnosis of thalassemia minor because his hemoglobin is that way only since the childhood, since the birth. So paying attention to that RBC count is important. Normocytic anemia can be, as I have told, it can be diagnostic anemia or even anemia of chronic disease. Many of our patients who are on metformin for diabetes or even rheumatic disorders, various rheumatic disorders, various nephropathy, various chronic illnesses. They do have low hemoglobin and it can be because of the anemia of chronic disease. Even sickle cell anemia. Many times we feel that
recording in progress.
hemoglobinopathy means MCV low. That is not the same. Yes, thalassemia syndromes are there in which hemoglobinopathy, in which MCV will be low, but in sickle cell MCV can be normal. So few days back we diagnosed 38-year-old female first time with thalassemia major, sickle cell disease. Up till now she never had any evaluation done for that sickle because MCV was normal, splenomegaly was there, intermittent jaundice, intermittent body ache, back ache, and now at the age of 38 she is diagnosed with sickle cell disease. And macrocytic anemia is also very common in India, particularly vegetarian. Particularly old age people, even if they eat good non-veg food, but still with age, the gut loses its ability to absorb more and more vitamin B12 with age, and that is why at the age of around 50, 60, they develop megaloblastic crisis or megaloblastic anemia. In that usually it is macrocytosis. MCV will be high on hemolysis as well. We had one patient who had been treated for megaloblastic anemia with repeatedly for almost 2 months, by many clinicians because MCV was on higher side and the hemoglobin was on lower side. And finally, when hemoglobin, even after blood transfusion and repeated Whitco falls, hemoglobin dropped to less than 2.0. She landed in ICU and now she turns out to be autoimmune hemolytic anemia. So in hemolysis, yes, MCV can be high. If someone develops again anemia even after blood transfusion, someone has to look beyond megaloblastic anemia because in megaloblastic anemia, what is lacking is vitamin B12, and blood is the excellent source of vitamin B12. You give blood transfusion, and still even after giving blood transfusion, someone comes with low hemoglobin soon, then that means something different should be there. Maybe minor dysplastic syndrome, maybe some other malignancy. So yes, we have to look into it whether someone has something else. Rating is also very important in routine immunization. The 5 minutes. If rating count is low, it can be marrow failure because of nutritional deficiency, anemia, chronic disease, or bone marrow failure. If it is marrow is good, there is no. If rating count is good, there is usually no role of doing even bone marrow. It does show that marrow activity is there. Marrow is productive. Marrow is producing more cells, and that is why reticulocyte count is something which gives us clue about the hypoproliferative or functional marrow what it is. So this is how usually these are the things which one needs to see into your CBC. Whenever hemoglobin is low, usually we rather than thinking on MCV or even RBC, we directly go for iron studies. And even iron comes normal or on higher side, then we miss things. Iron studies, iron is very labile molecule. It has to be done in fasting state. So usually we ask patient, come tomorrow morning in fasting state to do the iron study. Even ferritin is good enough to diagnose early or easily iron deficiency anemia. If ferritin is low, there is no any other video on this except for some rare congenital disorder with ferritinemia or hypoferritinemia anemia. So usually if ferritin is low, it has to be iron deficiency anemia. And on top of that, just diagnosing iron deficiency and giving iron to that patient should not suffice the purpose. We have to find the cause why someone has developed iron deficiency. It can be nutrition more likely in this scenario, but yes, it can be because of some blood loss. It can be because of some other menstrual issues. Even in old age people, it can be because of some gut malignancy as well. We had one patient who had every year in summer he used to take 3-4 blood transfusions, and 3 years consecutively this happened. And he came to me with bunch of files, including bone marrow report as well. That these are my reports. Every summer something happens back to me, and I need blood transfusion. What needs to be done? 65-year-old. I don't. We just have a hemogram. I just see a scale. You are like what blood areas blood to you. Then I have to tell him that let's do the stool microscope. Stool for occult blood. The stool for occult blood came for it. Endoscopy done in the NGM. He had isolated mass in the large bowel. And he succumbed within 3 months because already he got metastasis. So it was early lesion, which was bleeding slowly. He used to get 3-4 blood transfusion, hemoglobin used to go 12, and then again he comes back to the low hemoglobin. Just finding the cause of anemia that would have done 2 years back, he would have survived that illness. That is what I want to emphasize on that. So doing iron studies rightly, diagnosing the cause of iron anemia properly is important. Even anemia of chronic disease, in iron studies, if transferrin saturation is less than 20, there is always role of iron. Maybe not oral iron more, it is IV iron which is more useful in anemia of chronic disease. Because though iron is in your body, but that is functional iron deficiency. And in those cases, if patient is having normocytic or microcytic anemia, not responding to oral iron, and iron studies, fasting state that transferrin saturation is less than 20, maybe we can do trial of IV iron plus minus erythropoietin so that it responds very well. So this is how we have to look for the hemoglobin, MCV, MCC and other RBC parameters. Let's go to next parameter which are WBC. I usually get called, CBC is told on the line. Then next question from the epidemiologist come, what is the differential count? Because differential count is very important in this case. If it is gross neutrophilia, it can be more likely because of some infection or because of some malignancy which is myeloid. Like API, acute promyelocytic leukemia. 2-3 weeks back in Jalna, I saw one patient looking like frank, diabetic anemia or nutrition anemia. Young girl, 14-year-old, came with hemoglobin of 4.1, WBC count 3,900, platelet count 39,000. MCV 65 and weight was around 12-13 kg. She was looking already gigantic. I told father that yes, most likely this is nutrition anemia. Let me write some what do you call iron and vitamin B12 to her, and you come next week. I just examined her, and on examination I found some congenital hemorrhage as well. Her differential, I saw differential was showing 79% neutrophils. You know, 79% neutrophils doesn't look like something is bad. Why the heck she is having this congenital hemorrhage at the platelet count of 39,000? I told him that marrow needs to be done. As usual, he was like, "Sir, kal aate." And then on Sunday, he phoned me that I am coming in. He never came. And after 4 days, he was seen. I got a call from some other hospital that one patient is a 42-year-old girl. She is having intracerebral bleed. Please stop. I came there. I saw she was the same patient. She was already having intracerebral bleed, and patients were showing promyelocytic. It was acute promyelocytic leukemia, which had very good prognosis, excellent, almost 100% curability. But just because the slide was not seen or patient was not available at right time at right place, this thing happened. So that differential neutrophils may be minor variability, but usually we ask for that differential, and if lymphocytosis is there, yes, we usually insist for doing marrow or at least smear examination, because lymphocytosis, that reversal of neutrophil lymphocyte ratio, is something which we are actually looking for. So neutrophils are important in these cases where infection is the link, and lymphocytes are important when we are looking for something which is not in the marrow. Even megaloblastic anemia can also have the relative lymphocytosis, because megaloblastic anemia usually marrow failure there and they have neutropenia as well. But megaloblastic anemia is so common in India, we can have megaloblastic anemia along with this. That girl, she had nutritional anemia for sure, no doubt about it. But along with that, she had acute promyelocytic leukemia. So even lymphocytosis is there, and even if you suspect megaloblastic is more likely, doing marrow is never, you will never regret if you catch even one acute promyelocytic leukemia in your life, because that is life-saving. Otherwise, it is like a death sentence. Platelets are very important. Cells in our body, that is what everyone feels, and platelets is like, even when I go to call somewhere, people are like, "Aap become platelet doctor." I mean, since platelet body, they don't think I am the one who looks after the white blood cells and platelet. Another which is the doctor who does the platelets are important with something happening like this. When dengue and viral fever, all those things are going on, platelet becomes a big issue. People, patient, relatives, everyone is scared about that platelet. And a number of questions keep on coming to you. It is like a 100 issue that you are. And a number of things are there, why platelets are low, and a number of things are there, why platelets are high. We have one more next lecture going on thrombocytopenia, and Dr. Nilesh Vasu will cover that part easily. I just move to the second part of that lecture because Dr. Vinod Patil is not here. I am talking about when bone marrow engine stops working. Whenever a patient comes with pancytopenia to us, we have to pay attention to that patient rightly, because it is something which is like emergency. If severe pancytopenia is there, you may not be seeing that patient again, because severe pancytopenia with this COVID-like illness going around, they can catch any type of infection and they can die as quickly as you can't imagine. So paying attention why this patient having pancytopenia is very important. Grossly, you can say that these are the causes of pancytopenia. Whenever a patient of pancytopenia comes to you, make sure that you examine the spleen, because sequestration, splenic sequestration is very common. Many times we see early cirrhotic cases, even tropical splenomegaly, even some splenic lymphoma, all those coming with pancytopenia and splenomegaly. So seeing spleen, make it a habit that whenever pancytopenia case comes to you, you look into the splenomegaly whether found in the increased destruction, sepsis, DIC, all those things are there, and decreased production. There are a number of things. I just quickly go through important few investigations which we do and how we go into the thing. So megaloblastic anemia is very common cause in India when patients present with the pancytopenia. We have, and I have already told, pancytopenia, lymphocytosis, but seeing such a smear with teardrop cells, megaloblast, nutritional type picture, and hypersegmented neutrophils use much reading to us, and depending on that, we can decide whether someone needs marrow or not. Usually, they have little bit of indirect hyperbilirubinemia as well because of intramedullary hemolysis. These all RBC megaloblasts are stuck into the marrow, and it develops intramedullary hemolysis, and that is why they have indirect hyperbilirubinemia. Hypersplenism we all have already discussed. Yes, splenomegaly can be a cause for pancytopenia, and in that, if patient has pancytopenia, splenomegaly, on top of that, lymphocytosis is there, he needs immediate hematological assessment and bone marrow evaluation, because it can be because of MDS, it can be because of some lymphoproliferative disorder, it can be because of some myeloproliferative disorder, it can be because of anything on this planet. Yes, we have to see the marrow for this. More common than the marrow disorder related to splenomegaly and pancytopenia is liver cirrhosis, or early cases of liver cirrhosis, where patient develops pancytopenia and esophageal varices. So endoscopy is something which usually do. Autoimmune is also very important cause which usually we use. Patient develops pancytopenia, even young female pancytopenia, lymphadenopathy. We suspect some malignancy there. But yes, it can be because of SAE. Seeing the ANA by immunoblot or IFA method is important for these cases. And usually it is because of immune mechanism. We start them on steroid or some other immunosuppressive drugs, and they respond very well. Aplastic anemia is very important cause of pancytopenia, where bone marrow injury completely shuts down almost, and this is how the marrow looks like. This is hyperconfident of normal marrow, and the marrow shown in other picture is completely fatty replacement of bone marrow, that is pancytopenia and hypoproliferative or aplastic anemia. It is like a medical emergency. They need neutropenic care. They need immediate start of treatment as early as possible, either anti-thymocyte globulin or even bone marrow transplant. Bone marrow transplant has excellent result. If you ask me, which is the disease which is almost curable with bone marrow transplant, is aplastic anemia. ATG also has excellent results. Almost 90% of possibility is there that they will respond and they will become normal. So there are very good treatment options available nowadays with aplastic anemia as well. So are we referring to hematology, and quick diagnosis and treatment is important. APML, we have already seen that patient. Pancytopenia is the most common presenting feature for acute promyelocytic leukemia. If someone comes with pancytopenia and bleeding symptoms, yes, it can be it can be acute promyelocytic leukemia. And if WBC count is less than 10,000, it is very treatable because it is low risk. Even more than 10,000 WBC count, it is intermediate or high risk. Still, there are very gratifying results, almost more than 90%. Cure rate is there with acute promyelocytic leukemia, even without chemotherapy, with arsenic and atra. So seeing that patient of pancytopenia who doesn't have any hepatosplenomegaly, who have bleeding symptoms, even platelet count around 50,000, yes, it can be because of this acute promyelocytic leukemia. Heavy cell leukemia is also very common case presenting with pancytopenia, splenomegaly, and severe ischemic type of hairy cells. And this is also having very good prognosis. Nowadays, just recently, you all know that one of our stalwart social services, Dr. Prakash, he is suffering from this disease. He had pancytopenia, pneumonia, peripheral smear showed some lymphocytosis, marrow done, hairy cell leukemia. One cycle of chemotherapy, that is just cladribine, 5 doses, and it's almost 100% curable because we know the mutation, we know the disease how to target, and very good results are there with the treatment. Just diagnosing the early because they have lymphocytosis and they are very prone to develop various infections. So diagnosing early, treating early is the clue. Myelofibrosis is also one common illness which comes with pancytopenia, splenomegaly, a such type of teardrop cells and RBCs. Myelocytic, that is leukoerythroblastic blood picture is usually seen, and we can suspect why that bone marrow engine is not working. It is because of primary myelofibrosis or even secondary myelofibrosis. Some patients develop cough, or some patients have some breast malignancy, and still pancytopenia is there. We do marrow and then we see secondary is there. Prostatic malignancy coming with pancytopenia and secondary myelofibrosis. In ICU settings, yes, HLH can be there, which is hemophagocytic lymphohistiocytosis. Patients having pancytopenia, high fever, splenomegaly, not responding to antibiotics, progressively becoming sick. So yes, marrow looking for hemophagocytosis and targeting them early with the steroids, glucosamine or even cyclosporine is the clue for the secondary HLH. So to summarize, First part, complete blood count. Yes, we need to read it completely so that we don't miss many things which are given in that script given by the computer machine. It gives lot more information about the diagnosis and even the treatment, because we miss thalassemia minor, hyperthalassemia, even malignancy. It gives us clue how to further evaluate. Just paying attention, less than a minute you will need to see what exactly is happening in the CBC report, and depending on that you can say whether someone needs iron workup or someone needs HB electrophoresis. And iron studies, whenever you are doing, make sure that you are doing it in a fasting state. Pancytopenia can be a red flag sign, but still many hematological illnesses are there which can be either death sentence or just curable. So paying attention to pancytopenia, seeing what can be the cause of that pancytopenia, treating them as early as possible because it can be detrimental is something which is very important. And this is all from me. Thank you so much.
Thank you, Toshniwal sir, for this enlightening session.
Okay, as the chairperson, we would like to say two things. So it was our first session and covered the basic things of CBC and bone marrow. Because of automation, CBC has become a lot easier, and we old timers who have done hemoglobin and Japanese method. We staff at the young resident who are sitting here who have everything very ready made. But they have a problem because we used to examine hundreds and 200s of smears a day. So we know what is abnormal and what is normal in a fraction of a second. But today's speeches have to focus on morphology more. Otherwise, when your cell counter breaks down, you are in a quantity. That is one. And there are number of different types of cell counters, 3-part and 5-part. There will be limitations of both of the cell counters. 3-part will have limitation in that it won't pick up, it won't give you the blast flag. It will somewhere give some population in the mid segment, that granulocytes, lymphocytes, and mid segment. That will be the population where the blast cells will accumulate, where the promyelocytes will accumulate. So we have to look at the mid population. And then again, there are a number of situations in which CBC can go wrong. So there will be spurious rise in hemoglobin. If you have a very lipemic sample, that you have to check. Then there will be, of course, platelet clumping, all of you are familiar with. So basically, complete blood count is incomplete, I would say, without proper understanding of limitations of the cell counter and proper interpretation of the peripheral smear in light with the clinical findings that are given to you. And regarding bone marrow also, there are a number of things that we have to keep in mind. Of course, the proper preparation is very important. Otherwise, whole of the effort of examination of the bone marrow will go waste. If the smears are not prepared properly, they are very thick, or if your tissue processing is not good, so that you are not able to interpret anything in the biopsy specimen. So, with these few points, I would like to congratulate Dr. Manoj Toshniwal for organizing this summit and set the ball rolling with a very interesting lecture. Thank you very much. Do we take the questions now? If there are any questions, audience, please over to you now.
We do feel that IBI is far better than oral something which is not good. But let me be very clear on this one that all the iron molecules are almost equal, little bit here and there, and oral iron still has very good role. Problem with oral iron is that 70% of them do have some or other side effects associated with that, particularly GI side effects. Not feeling well, uneasiness, loose motion, constipation, or hiccup, all those things. If patient is not tolerating oral iron, then only there comes the role of IVI. If someone is in hurry that some surgery needs to be done in 2-3 weeks time, 2-3 weeks time, not in 1 week, IVI for sure is not the answer. If hemoglobin is very low, surgery is time, give blood and then go. But if 2-3 weeks time is there, yes, one dose of IVI, given molecule, maybe carboxymaltose or isomaltose, that can be used. But usually for other patients who routinely comes to our OPD practice, yes, we can go for oral iron. But along with oral iron, yes, proper counseling of diet, proper counseling of compliance, and proper counseling of duration of treatment he or she needs is very important. They start taking oral iron, in a month's time they start feeling better, or they start feeling worse because of the side effects, and they stop. So if that has to be avoided, if you doubt that compliance is the problem, maybe you can do IVI to get whatever desired hemoglobin level is there. But if patient can be counseled rightly, diet modification, cause you all know, yes, oral iron still has very good role, and it is still the most common mode of iron supplementation in the country. Thank you. Yes.
Yeah, what is your indication for IV blood transfusion in iron deficiency? At what trigger?
Thank you so much, sir, for this question. Yes, this is a very important question. All of us do have. Patient does have frank iron deficiency anemia. We all know that clinically diagnosis is iron deficiency or nutritional anemia for that matter. And now hemoglobin comes 3, 4, 5. Whether to go for transfusion, go for oral iron or IVI. If clinically patient is symptomatic, then only blood transfusion is indicated. Otherwise, if patient is stable, doesn't have any major chronic illness, no what you call respiratory or cardiac compromise is there, still oral iron remains good, diet modification remains good. At most, if you want to go for early or even you suspect compliance is the issue, maybe you can do IVI. Blood transfusion itself has many hazards. One has to keep in mind giving blood transfusion. Before that, one must have to think 10 times that is this the only option which I have. If someone is having frank bleeding, that is the reason why he or she is having iron deficiency anemia. In that case, rather than barking on oral iron, maybe supplementing with blood transfusion can be better thing. Because if she develops next day heavy bleeding and she lands up in syncope and ICU, then you will be regretting that I should have done that. So if ongoing loss is there, yes, blood transfusion. If immediate in a week or two surgery is planned, hemoglobin is very low, yes, it can be given. And if patient is symptomatic and some other associated illnesses are there which warrants early recovery of hemoglobin, maybe in those cases can become better. Thank you, sir.
I have got most of the physicians may write iron oral after food. It has to be taken before food. And don't be driven away by remarks. You have to select your iron molecule very carefully. We have to prefer ferrous sulfate. Then the second issue is, can you explain in details? There is a huge data regarding IV iron therapy in CCF patients. They have demonstrated there is less transparent saturation. Though the iron levels are normal, though the hemoglobin is normal, still they are recommending IV iron therapy in CCF, very specific scenario. You can just explain us which patients of CCF do qualify for IV iron therapy and who do not qualify.
Yes, very important. Mark. One thing is that counseling, how to take iron is very important. How long to take iron is very important. Iron, I have also told, it is very labile molecule. People take after food, it is useless because absorption gets hampered. With milk contains calcium. Calcium is very good chelator of iron. They take iron pill along with calcium as well. They take iron pill along with acidity of the iron taking always along with the iron molecule which we have prescribed. Actually, acidic environment is needed for. So, giving unnecessary PPIs or even calcium supplement with iron preparation should be avoided. Almost all iron preparations are equal. Nowadays, many good molecules recently are coming into the market. Second thing, which is very important, congestive cardiac failure cases. Yes, there is very good data. Randomized controlled trial about in congestive cardiac failure cases with role of IV iron, IV of CM1 If we do fasting iron studies, if transferring saturation is less than 20, that says that patient has functional iron deficiency. Even if hemoglobin is 30, even if ferritin is normal or on higher side because of ongoing inflammation in the body. But if transferrin saturation is low, it gets benefited by at least 500 or 1000 milligram of IV iron given to the patient. It gives overall feeling of well-being, it reduces the overall hospital admission, it reduces the overall shortness of breath, other symptoms associated with the congestive cardiac failure, it reduces even use of diuretics in congestive cardiac. These are the parameters they are studying in the randomized control trial. Yes, just to clarify your question, if transferrin saturation is less than 20 in fasting iron studies, there is a very good role of IVI. Thank you, sir.
I request Amrut sir to felicitate our speaker, Dr. Manoj Toshniwal.
I congratulate Dr. Manoj for organizing such a nice CME. And it's a very nice and he's accomplishing himself as a good hematologist in this area. Thank you.